Good evening, friends, and a warm welcome to this episode of 4D Detailed Discussion and Diabetes. Detailed discussion and dialogue in Indian diabetes. It's not just discussion, it's dialogue. And for dialogue, of course, you need more people than one, isn't it? So let's welcome our dashing team today of dynamic doctors, people who handle metabolic syndrome, the various facets of diabetes and related diseases, and who help make our country healthier and happier. A warm welcome, first of all, to Dr. Sahil Bagai, nephrologist at Fortis Hospital in Manesar, Haryana. Warm welcome, Dr. Sahil.
So I am a senior consultant and head of unit at Fortis Hospital, Manesar. I did my DM nephrology from PGI Chandigarh. So I'm a PGI alumnus. And very excited to be here amongst all the stalwarts and would be keen to share my views on metabolic syndrome and in regards to kidney. Thank you.
Thank you, Sahil. Though there is a friendly comment coming your way from Safdarjung Hospital in New Delhi, and Dr. Saurabh Sharma says you are senior, we agree in terms of years, but you don't look all that senior. So that's
I'll take that comment gracefully.
Yeah, and it is the comment is sent with affection and grace. That's right.
Absolutely.
We also welcome Dr. Rahul Parashar. Dr. Rahul is a young and very enthusiastic endocrinologist working at Kailash Hospital in Noida, Uttar Pradesh. Warm welcome, Dr. Rahul.
Thank you very much, sir, for this very kind gesture. Honor is totally mine to be in front of you because you being an endocrine stalwart and believe me that I am reading your publications, your videos that is guiding me through the path of endocrine care in today's era, and that would be a very big help from you. And so it is a privilege and an honor for me to be here and sharing the screen with you. And thank you for this introduction, sir.
Thank you so much. But the privilege is ours, actually, Dr. Rahul. The concept is mutual mentorship, and we learn a lot from our younger stalwarts, and they are the real stalwarts, people who actually carry they shoulder the burden of endocrine and diabetes care on their shoulders. So thank you, Dr. Rahul, not only from my side, but from all those who are listening to you, that is, citizens from across the country. We also have with us Dr. Yogender Singh Rajput. Dr. Rajput is a cardiologist working at Marengo Asia Hospital in Gurgaon, again in Haryana. Warm welcome, Dr. Yogender.
Thank you, Dr. Kalra, for introduction. I am Dr. Yogender Singh Rajput, and I am an intervention cardiologist and settled in Marengo Asia Gurgaon, as rightly said. And we actually dealing with, the today's topic is very close to my, heart because I have done some thesis work in my PG time on this topic. So metabolic syndrome and all that, because that time when I was doing my graduationship and post-graduation, this was an emerging topic because we were dealing with obesity and insulin resistance. Now it's established a cause for multi-organ dysfunction involving endocrine, nephrologist, and all the people. So I think it will be good discussion. We all are here to discuss and collaboratively we will find out some solution. How can we deal with this metabolic syndromes? Thank you, Dr. Kalra. We'll go ahead with this.
Thank you so much. And you're right. Together, actually, we can find lots of solutions. We can share insights, share information, learn from each other. Dr. Rahul, many times I think about philosophy. When you look at Western philosophy, in general, it is a linear kind of a philosophy. Today you're alive, you do good things or you do bad things, then tomorrow you go to heaven or hell. So it is linear and it is finite. But when we look at Indic philosophy, whether it is Hinduism, Buddhism, or Jainism, then it is a cyclic kind of a philosophy. Jainism is the nicest and the most optimistic of most of our religions because they say you will always have cycles of good and bad. But rest assured, the good cycles will be longer and stronger. The bad cycles will be shorter and milder. A similar thing seems to be playing out in metabolic syndrome. So maybe when I was a student, maybe 3 decades ago, there was this flowering of super specialties. So you would have people who would say, I'm going to do only cardiology, only endocrinology, only nephrology. And internal medicine was torn apart into various bits and pieces. So much so that our colleagues in cardiology would assume that there are only coronary arteries in the heart. There is nothing else in the heart, So maybe as a student, for me, pericardial effusion, rheumatic heart disease was the biggest challenge. By the time I passed my exams, nobody was talking about them at all, and they were talking only about coronary arteries as if there is nothing else. But keeping in view this Indic philosophy, now what has happened is that again there is a reflowering or a restructuring, and all those petals, sepals which had been torn apart, they are all coming back now. And now we talk of holistic medicine, comprehensive medicine, and we talk of metabolic care instead of talking about uh, endocrine and maybe cardiac or renal care. So let's take this into endocrinology, Dr. Rahul. When we study endocrinology, we study various glands separately. But from a metabolism point of view, do you think that the pituitary, the thyroid, the parathyroid, the adrenal gonads, let's take them one by one, maybe any two glands that come to your mind, apart from the pancreas, do you think they also contribute to metabolic syndrome?
Definitely, sir. And in today's world, what I believe is that this body is like a string of beads. So the beads, they are connecting the system. So these beads, they are the hormones that we are talking about. So we all know for time being that this metabolic syndrome, it has its core pathophysiology is the insulin resistance. So now if we talk about the insulin resistance, so where did this insulin resistance came from in the first place? So people have forgotten about this topic altogether. They are just thinking that insulin resistance is there and let's deal with the insulin resistance. So, but dealing with insulin resistance, first of all, we have to know that where did this insulin resistance came from. So if we look at the prior data, so if we see that we are already suffering from the thrifty genotype hypothesis, that Indians are strongly inherited by this thrifty genotype hypothesis. So what did that hypothesis signify? That means that Indians, they have a storage capacity of extra fat, that when we are getting excess energy, and that is why we are storing it more, because we were meant to starve in the environment, and when we got the excess energy, we are storing it as fat. And similar kind of things, they percolated in our generation by generation, wherein our children, they are fed high fat, salt and sugary foods, wherein they are eating more calories as they are spending it. So this approach of this collaborative effort, so this is increasing the stress hormones. The stress hormones being first of all cortisol. So this cortisol has a very positive and in certain situations and a negative effect. So the adrenal gland is a very important hormone in such situations, wherein it leads to difficult to control weight. So जो आज की डेट में हम जिन पेशेंट्स की बात करते हैं, जो हमारी ओपीडीज में आते हैं बहुत फ्रीक्वेंटली, दैट सर मेरी बॉडी फुली रहती है, मेरा वेट कम नहीं हो रहा है डिस्पाइट लाइफस्टाइल एफर्ट्स. सो जिसमें हम जो हमारा एक सबसे पहला पिलर है लाइफस्टाइल मॉडिफिकेशन, वो उसमें हमें काउंटर करना है द स्ट्रेस हार्मोन. So the first gland that I would like to highlight is adrenal gland. Then comes this adrenal gland से होने वाले counter regulatory factors. वो counter regulatory factors, these stress hormones, they lead to further enhancement of the other stress hormones from the pituitary and hypothalamus, so which further aggravate this weight gain cycle. So the two most important glands that I would like to highlight from this, apart from the pancreas, for this weight perspective, is this pituitary and our this adrenal gland.
So this makes sense, and we realize that when we speak of metabolic syndrome or even about diabetes or obesity, we have to think beyond the pancreas. We have to think beyond the conventional pathways that we are taught. And there are so many contributing factors, so many confounding factors. Dr. Yogendra, we just said, and of course in a lighter vein, that apart from the coronary arteries, there are other aspects of the heart and the vascular system. So again, let's go through them one by one. Let's begin with a disease, maybe let's begin with anatomy. The pericardium, the epicardium, is this of relevance to modern cardiology, both from a diagnostic point of view? When on echo you look at the pericardium, epicardium, can you find ways, which tell you, yeah, there is ectopic fat, something is going to go wrong, something is going to go right? So let's just talk about epicardium, pericardium, and then we move into the heart later on.
Yes, sir. So because most ignored layer of the heart is actually pericardium and epicardium. So most of the people talk about myocardial infarction. So it is very common because everybody is because it is the thickest part of the heart, and everybody is mainly concentrating on the myocardium because it has been supplied by the coronary artery. Though we also consider epicardium and as a pericardium also very important. Why? Because epicardial fat, some studies has been found, though there is not a very convincing data, but epicardial fat is one of the risk factor assessment in some studies. If you have a very high level of epicardial fat, by looking into a simple echocardiogram, if you do a simple echocardiogram, you can analyze like a risk marker that you may have somewhere high metabolic, high cholesterol in your fat, in your blood, or there could be chances that your triglyceride or something will be high. So there are certain correlation between the epicardial fat and coronary artery disease or a peripheral artery disease or even a cardiovascular risk marker like other risk marker like carotid intimal thickness or you have a retinal artery disease. So these are the risk markers where you analyze these markers. Similarly, the epicardial fat is one of the marker which we can analyze by simple echocardiogram. Same thing is epicardium, though epicardium we cannot see, but their dysfunction can be assessed by the echocardiogram. So it is also by simple echo. If we see a diastolic dysfunction, it is the one of the marker or early marker of diastolic dysfunction. And diastolic dysfunction is now emerging as one of the difficult to treat disease, because if you find out early diastolic dysfunction and you work on the risk factor, you can prolong the life. Otherwise, if it goes beyond the uncontrollable level of diastolic failure, then we don't have much treatment left for the diastolic heart failure. For a reduced ejection fraction, we have multiple modality of treatment. For a preserved ejection fraction, few therapies are there, but not very convincing and very difficult to treat. So these two, epicardium and pericardium, are very actually coming up and simple way to diagnose few diseases. And I think when we discuss about coronaries and myocardium, we'll discuss further.
So this is really interesting, and now I am also becoming intrigued. We use the word metabolic syndrome so loosely. Then when we use it, we focus on the specific definitions. And I always, as a student, I found it very difficult to remember the definition of metabolic syndrome. But then I am a native Punjabi speaker, so we remembered the word dhol. Now in Hindi, it is dhol, D-H-O-L. In Punjabi, it will become tol with an extra L. But if you move to Uttar Pradesh, where Dr. Rahul is working now, then it becomes dholki, Ki with a kidney. So dhol would be dysglycemia, high blood pressure, heart disease, O for obesity, ovarian disease, that's PCOS, and obstructive sleep apnea. L would be liver, lipids. When you have the double L in tol, then it is two types of lipids. And perhaps Dr. Yogendra later on can talk about the importance of LDL as a therapeutic target vis-a-vis the importance of HDL and triglycerides as a diagnostic tool. When you're diagnosing metabolic syndrome, then suddenly your rules change. And Ki would be kidney. So kidney is important. But of course, we realize that the kidney is a very shy kind of an organ. And in the Hindi movie, the question was choli ke piche kya hai? But Dr. Sahil later on will tell us कि retroperitoneum के पीछे क्या है, what is there behind the retroperitoneum. But while we wait for Dr. Sahil, Dr. Rahul, you have spoken about the adrenal. There are other glands as well. Now this word MARS, metabolic associated reprosexual syndrome, MARS, metabolic associated reprosexual syndrome. What would this mean to you? Let's take it from a women's point of view first, and then later on we move to men as well as we discuss further.
Definitely, sir. So if we all are aware about the recent developments in the development of this metabolic reproductive syndrome. So recently, the name for PCOS has already been revised to polymetabolic endocrine syndrome. So that has been revised. So now, why it was revised? Because the certain authoritative guidelines, they realized that what is the basic pathophysiology behind it. So it is the metabolism that is the key driver for the changes that females are experiencing, the reproductive dysfunction that is going on in the females. So the main driver was the metabolic dysfunction. So why did this metabolic dysfunction occur in the first place? Again, the basic pathophysiology remains the same. The insulin resistance was the key driver, And then that insulin resistance, over spillage of the ectopic fat deposition that Dr. Rajput has already highlighted very well. So that ectopic fat instead of the pericardium also is deposited in the different organs of the body, which leads to excess hormones being developed from the dysfunctional adipocytes, which are disturbing the normal our HPO axis, that is hypothalamic pituitary ovarian axis in terms of the, in cases of the females, and in terms of the males, the hypothalamo pituitary testicular axis. So these are the, because the dysfunctional adipocytes, they are now considered as well endocrine organ which secretes active hormones which are influencing our hypothalamic pituitary axis as well.
And Dr. Yogender, now Dr. Rahul just spoke about metabolic associated reprosexual syndrome. There can be an impact on reproduction. There can also be an impact on sexuality. And these are important aspects of life. Many times the patient comes to us, we get busy in managing the blood pressures and the lipids and the glucose levels, and we forget to talk about things that actually matter to them. So a question from a cardiology perspective, when you are handling cardiac disease, do these issues come up? Reproductive issues, contraception, conception, sexuality, or do patients remain silent? How does it work out in the average cardiology OP?
So, actually speaking, people who has a cardiac disease, established cardiac disease, or when we should just discuss between the male and female different issue. Like female comes with different issue and male come with different issue. So male mostly has a issue with either a sexual dysfunction or decreased desire due to medicinal effects, like if we use beta blockers or something to treat any sort of disease like angina, hypertension, then they have these issues in cardiology related to drug-related side effects. Or sometimes they are more worried post-procedural assessment, like whether we can do some sexual activity if we have a heart attack or LV dysfunction. So we need to encourage them so that you can assume your normal sexual activity after the procedure, though there will be some side effect of the medication. So there are a men's related problem, though women's related problem are less because they don't aware and their symptoms are very subtle, and they don't recognize. Actually they think it's like a normal problem which we are facing. Though some ladies which are on hormone replacement therapy, they do feel and they develop more dyslipidemia sometime, because if we are giving or HRT or something, they develop dyslipidemia more. And there are some controversy behind the HRT, so they don't aware about the HRT. Like some ladies feel better with the HRT, but they have developed some cardiovascular issues because of HRT. HRT causes insulin resistance also sometimes. So there are problem with women for sexual assessment is very difficult to analyze also. But for men's, there are problems and we have solution for them and we guide them accordingly.
Thanks. Before we go to Dr. Rahul and Dr. Sahil, let's put things straight. Actually, hot flash, that is vasomotor symptom, is first of all a differential of angina. The same symptoms for angina, the same symptoms for hot flash, vasomotor symptom, and the same symptoms for maybe hypokalemic periodic paralysis or for an acute panic attack. So there can be an issue in diagnosis. Secondly, vasomotor symptoms are an anginal equivalent, and women who have severe VMS, vasomotor symptom, actually have higher chance of cardiovascular disease, higher chance of premature mortality as well. So it must be treated. Lipids is an issue. If you have someone with high triglycerides, then transdermal estrogen would be the best bet, and that is very, very safe to use. Yes. There is an issue with language as well. So let's get Dr. Sahil into the picture. Warm welcome, Dr. Sahil.
Yes, sir.
Dr. Sahil, India wants to know, the nation wants to know, retroperitoneum के पीछे क्या है?
Yes, sir. So we all know, sir, there are two organs which we generously call kidney, which are going to filter your waste and is going to take care of lots more things, just more than just filtering your waste metabolism. Yeah. So in terms of, so if I have to answer in terms of metabolic syndrome, I would say that kidneys are going to take a brunt of all the muscle metabolism and fat metabolism that's going to happen. And since it's a product of wear and tear, so I believe that the more stress you put on the kidneys, and that too at earlier ages, the more detrimental it is going to be for everyone, and obviously the repercussions are going to be very strong and hard at the back end of your life. So that's how at least from a nephrologist perspective, I would put as a metabolic syndrome causing renal.
From a physician's perspective and even from a public perspective, the kidneys have always been very secretive organs. The reason is that they were retroperitoneal, and initial dissections were done on animals like the sheep, for example. So you have to really dig in to find the kidney. And even in human beings, earlier dissections were not allowed. So, you could see the heart, for example. Everybody knew that the heart exists, the liver exists. So that is why there are so many Bollywood songs on the heart and on the liver. But you don't know where the pancreas is, and the total weight of the beta cell is only 0.8 gram in a lean adult, 1.2 gram in an obese adult. So how will you find it? Then the Hindi word for pancreas is agnashya, वो जो अग्नि का नाश करे. So again, something very secretive, something very high level. For kidneys also it was like that. But it's now just in recent years that we've been able to figure out how to screen, how to monitor renal function, and that is why our treatment is becoming better. But Dr. Rahul, let's come back to that aspect of metabolic syndrome. We've talked of various glands. We are talking of the adrenal, we are talking of the gonads. But what about the bone? And would you like to talk to Dr. Sahil? The bone, is it an endocrine organ, or is it just musculoskeletal? And then the kidney, do you feel that the kidney is endocrine organ apart from being an excretory one or a metabolic one?
Definitely, sir. These both things, they already have been proven that even bone and kidney, they are secreting the hormones, including osteocalcin and our FGF23, and along with the controlling the calcium and the phosphorus metabolism by the renal system, the production of vitamin D, and including alpha klotho and a lot of other factors as well as. So both of these organs, they are I believe to be them as an endocrine organs as well. But definitely Dr. Bagai will also enlighten us regarding the excretory part of the there are two aspects of the renal system. So one is the excretory function and the other is the endocrine function. So the endocrine function I am talking about, and I believe the rest remains is the excretory function, and Dr. Bagai is much more expert than me for this.
Dr. Sahil, a question for you. This comes from a fellow nephrologist. His name is Dr. Sahil Kharbanda. He works in Karnal, and he's also a PGI alumnus, young in practice. And he says, "Sir, I struggle with explaining to my patients why I need an EGFR and a UACR both. Why is one not enough? How do I explain in simple words to my patients that both verticals are equally important?" Yeah, Dr. Sahil, please.
So, as so it does not limit to its weakness, it is secretion also. So, by year 23, and there is a vital molecule which we and there is a lot of complex interplay between the so I would put across that itself is it has its excretory as well as secretory function. So can be relatively termed as an exocrine.
Thank you. And Dr. Yogender, the same question for you. When we want to, let us say, screen for or we want to diagnose heart failure, why is it that both an echo and NT-proBNP are required? Why is one not sufficient?
Sir, actually, echo has their own limitation, and the learning curve is actually bigger for some people, because diagnosing, as I already told you, diagnosing a heart failure with reduced ejection fraction is much easier compared to the HFpEF, heart failure with preserved ejection fraction. though both are considered as a heart failure stages, and both has the worse prognosis. In all the studies, it has been seen that reduced ejection fraction, and even though preserved ejection fraction carries the same prognosis, though preserved ejection fraction carries worse prognosis because we don't have limited medication for that. So to diagnose in precisely, if echo is somebody saying normal, though pumping is normal, though pro BNP is a very sensitive marker, despite there are some limitation because it increase in some other non-specific causes also like CKD, sepsis, it can increase. But if you leave aside certain things, it is very good marker to analyze heart failure. If your BNP is high, above its normal range, you can easily diagnose that patient is suffering from heart failure, and you can keep the rest of the things aside, like respiratory and other causes aside, and you can concentrate on treating a heart failure. Even you can prognosticate also if BNP levels are going down over a period of time after a treatment. You can reduce the medicine, you can up titrate your medicine. So BNP is a very specific marker, and that should be considered in any heart failure. Echo has a dicey problem, as I already told you, because if you don't have a reduced ejection fraction, preserved ejection fraction is always a problem.
This specific question about limitations of echo and anti-pro-BNP, and then after you we move to Dr. Sahil. But in people living with obesity, what are the specific challenges that we will face when we do an echo? And then people living with obesity, how do we read the anti-pro-BNP?
So obesity as such, so there are specific guidelines that suppose somebody has so obesity is a metabolic disorder, and especially people with obesity with metabolic disorder has more chance of diastolic dysfunction. So usually we prescribe, like patient with obesity usually come with breathlessness, symptoms of breathing problem, and we want to diagnose the heart failure in such patient. We need to analyze both the things, echo as well as the pro-BNP. Though pro-BNP sometimes increase in obesity because it is pro-inflammatory conditions are going on, but if the levels are very high, like beyond 3 times to 5 times, it is mostly because of the heart failure rather than other conditions. So, and if your echo is supporting it, like diastolic more than grade 3 heart failure, it is also suggests that you are suffering from heart failure with preserved ejection fraction, and we should treat it accordingly.
So both are important, and then, but the point I'm getting, Dr. Yogender, is that you need an astute clinician, an astute cardiologist to be able to read these values also. You just don't go by the numbers or by what is written. Would that be a right interpretation?
Yes, correct, sir.
Thank you. Dr. Rahul, so, now we suddenly see that metabolic syndrome is becoming more and more intricate and more interesting as well. We never thought that there were so many, ifs and buts to metabolic syndrome. The Hindi word for octopus is Ashtbhuja, 8-armed or 8-legged. Would we be right in saying that metabolic syndrome is like an octopus of medicine? And then since we've brought in the number 8, what does 8 mean to you as a metabolic physician?
Sir, regarding the metabolic, as you have very well highlighted the 8 arms of the metabolic syndrome, and definitely I would like to quote one of your videos as well. So wherein you said that despite being years and years of talking about metabolic syndrome, we are still on that page where we are still in 2026 talking about the metabolic syndrome. Sir, if you look at the National Family Health Survey data, so that was published in May 2026, and the data was for 2023-2024. So it very well highlighted the burden of overweight and obesity among adults. It has reached up to 44%, and that was in females and 36% in males. So this was the urban data. So rural data was somewhat less, but we all know that because of the availability and facilities, the urban societies, they have a much higher burden. And the more interesting fact is that in one of your papers, it was very well highlighted that this burden is projected to rise by 60% within a span of next 50 years. So almost if you believe that 60% of the population is obese or overweight, so that is a very huge number, sir. And coming on to the 8 arms of this metabolic syndrome, So as the science is progressing, we are realizing the very negative roles of insulin. That if in we have started to realize that insulin is an anabolic hormone. So if anabolism is persisting for a very longer period of time, that is negative for any part of the body. So as the time is progressing, and even in very recently concluded ADA 2026, they have highlighted that this insulin resistance is now divided into primary and secondary. So this secondary is one which is due to the lifestyle factors because of the excess energy supply that we are talking of, and the primary one is because of the genetic syndromes wherein due to dysfunctional insulin resistance and all, there is increased dysfunctional insulin signaling leading to increased weight gain. So we are leaving aside the primary insulin resistance, we are more focused on the secondary insulin resistance. That is the talk of the today. So considering the 8 arms, so out of that 8 arms you have very well highlighted the all of 8 arms like dyslipidemia, hypertension, obesity and overweight, the lipid abnormalities, the then PCOS abnormalities you have highlighted, the kidney injury that you have highlighted. But I believe that this all of these 8 pathophysiological defects that not pathophysiological defects, the 8 of the arms because of metabolic syndrome that we have highlighted, because the common driver for all of these problems is insulin resistance. The newer terminology that is being propagated in today's world is CKM syndrome also. So you have done a very well research on that also, that in newer world, so we are highlighting the CKM syndrome and its stages. We are promoting this approach of medicine towards the preventive care.
Thank you so much. Dr. Rahul, Dr. Yogender, does this work in cardiology as well? So two concepts which Dr. Rahul shared. And then, first of all, he said insulin is anabolic. But if you have too much of insulin, it becomes maladaptive anabolic. Would we be able to explain heart failure in this way? Heart failure with preserved ejection fraction is like maladaptive anabolic heart. Heart failure with restricted ejection fraction is like a catabolic heart. Would this make sense to a cardiologist's brain? And then how do we use this analogy? How do we take it further to explain to our patients the second part, which Dr. Rahul said, that instead of just treating the disease, we want to prevent it. So cardio, renal, metabolic disease, we want to prevent that. So what can we do from a prevention perspective in the cardiology OPD?
So your voice is breaking. I am not able to hear you. Hello.
So how do we?
Can you repeat the question, sir? It was total disturbed throughout. Hello.
Can we explain heart failure, the spectrum of heart failure, through the spectrum of metabolism?
Still.
HuffRef is catabolic. HuffPEF
Yeah, sir.
is maladaptive anabolic.
Sir, frankly speaking, I understand that this HuffPEF or HuffRef is actually, I think it's a catabolic disorder only from my prospect, because we have these things arises because of definitely because of the metabolic syndrome, which is the primary driver is the insulin resistance, and because of the pro-inflammatory marker which are released into the body, which causes the endothelial dysfunction, and endothelial dysfunction ultimately leading to the muscle damage invariably in any form, and it'll ultimately lead to the either a diastolic heart failure or a systolic heart failure. Mostly it is a diastolic heart failure. So I personally feel it's like it's a disadvantage of being a insulin resistance and ultimately leading to the heart failure.
You're right, and everything gets interlinked. Dr. Rahul, let's look at the concept of sarcopenic obesity. Now, when you see the person from afar, everybody with obesity is maladaptively anabolic. When you see the person from afar, everybody with HuffPEF is anabolic. Their heart is kind of like strong, and there's lots of muscle, lots of ventricular mass, lots of atrial mass. But when you go closely and you look at sarcopenic obesity, then you realize that it is actually a catabolic stage. Can we use this analogy to explain the difference between HFrEF and HFrEF? And how do we, as we talk about it, first you and then Dr. Yogender, does it make it easy for us as physicians to explain to our patients what we are trying to do and the challenges that we are facing as we try to treat them?
Sir, definitely. We all know that a failing heart releases certain substances that includes promotion of TNF alpha. That is the main modulator for cardiac cachexia that we all know of. So this TNF alpha is breaking down the muscular component of the patient. So wherein the patient lands up with sarcopenia, and we all know that this failing heart, it will lead to increased water retention. So that increased water retention will the patient will be a little bit puffy with reduced muscle mass, and this reduced muscle mass will lead to his functional and decline. So that is the component of sarcopenia. And if we talk in terms of the sarcopenic obesity component in patients with HFpEF, so in those cases, what is happening is, due to overweight and obesity, the excess is being spilled into the muscle as well. That is leading to myosteatosis. So this myosteatosis is the major driver for sarcopenia in patients with HFpEF. Whereas this inflammatory cytokines, they are the reason for sarcopenia in patients with HFrEF.
And Dr. Yogender, your comments on this. Now we see that we are talking of heart disease, but there is a metabolic basis to it. So this is also part of metabolic syndrome. The question coming from the audience is, how do we explain this to the patient, and then how does this inform our choice of treatment, both therapeutic and preventive?
Sir, actually, in case of metabolic syndrome, we know that there are multiple things start working, like oxidative interleukins are released. There are RAS system activation, endothelial dysfunction. So all these things, when combined together, ultimately lead to the heart failure. So what we tell the patient, if you are suffering from metabolic syndrome, which we have a diagnostic few criteria, you need to do workup for your heart also, because somewhere you will have some heart disease or some heart failure. If we start treating right away these metabolic problems, you can be disease free for a long time, sir. So I think as a layman, as a physician doctor, we always tell, if somebody is suffering from a metabolic syndrome, you consider it like they are at the risk of heart disease. And if we try to treat them, heart disease in the form of diastolic dysfunction or a coronary heart disease later on, we need to start work on right away. We should start reducing the weight. We should start treating the hypertension, pre-diabetes. If you treat all these things, I think we can prevent the heart disease. And my experience is that if we treat all these things, we can prolong the life and people can live as long as they want.
Out of all the muscles in the body, so this is a question to everyone who is listening to us, which is the strongest muscle in the body? That's one question. A slightly tougher question, which is the strongest muscle per unit mass? So that means this is the mass of the muscle, how much strength does it convey, how much force? And then the googliest question would be, which animal has the maximum number of muscles? And I just put in perspective, it is not the human being, it is not the elephant. Elephant and humans have the same number of muscles.
It's the bee.
Dr. Rahul would like to take a guess. Which animal has the maximum number of muscles? Yeah.
Sir, it's the bee.
Bee. The bee and the caterpillar. They have the most. Yeah. But Dr. Yogender, does the word muscle come into your conversation? Muscle, maspeshi, does it come into your conversation as a cardiologist? If yes, then why? And if no, then how can we use the word muscular health to promote a better lifestyle in heart disease?
This is a tricky question actually. Sir,
because the heart is
talking about the muscle.
The heart is a muscle.
Yeah, so heart in total is a muscle actually.
Yes.
So heart in total is a muscle only actually, and it continuously beating throughout the day without relaxing till your life. So like if you have a full lifespan of 70 years, it will not stop for a minute or even a second. So heart in total is a muscle. So I personally feel that heart as such muscle is a strong muscle, and we should protect this heart muscle by means of controlling all the risk factors.
So perhaps if we start using these words in our OPD from tomorrow onwards, and we say that, yeah, this is a muscle, we need to take care of it. The same way that you take care of other aspects of your body, you take care of your muscle. And then, Dr. Rahul, would there be a muscle-muscle crosstalk in the sense that if I take care of maybe if I take care of my quadriceps, if I take care of my biceps and triceps, automatically the heart muscles will become better. And then vice versa. If Dr. Rajput takes care of my cardiac muscle, then I will be able to exercise my biceps and my quadriceps better. So let's take the question both ways. First Dr. Rahul and then Dr. Yogendra.
Yes, sir, definitely. That there is a proven muscle-muscle interaction is there. So wherein if a patient is exercising, so that will increase the blood flow, increase the demand, increase the glucose phosphorylation. The inflammatory cytokines will be less. There will be a less inflammatory environment that will protect from what we call as the plaque generation or the atherosclerosis of the arteries. So in a late stage, so if a patient is exercising for a very long time, so they have very clean arteries, what we say in normal layman sense में जो हम बात करते हैं कि जो लोग exercise करते हैं regularly, उनकी arteries they stay healthy for a longer period of time. So that is the whole sole basis of that because of the exercising muscles, they are utilizing the fuels more efficiently. That fuel, when it is cleaned up, so that जो remaining part है, that is also efficiently metabolized by the rest of the body. So instead, जो patients exercise नहीं कर रहे हैं, they will have their over spillage of the fat into the every part of the organ. So that is the crux of the talk here, the metabolic syndrome. Because of the components of the metabolic syndrome, this overflow of fat is to the every part of the body. That is why leading to the dysfunctional metabolism and dysfunctional heart.
So when we exercise, we secrete more of happy hormones and we secrete less of the harmful hormones. And Dr. Yogendra, how does it work from a cardiac muscle point of view? And how can we use simple words to convey evidence-based messages to our patients?
Yes. So the thing is that definitely muscle-muscle interaction, as rightly said by Dr. Rahul. So आप अगर exercise करते, if you do exercise, they releases positive hormones like endothelins, and they reduces the inflammatory marker like interleukins. What the endothelins and nitrous oxide do, actually, I personally observe, and we have a scientific data behind it, that if the nitrous oxide and endothelin release, they form the more collateral in your arteries. So there are few data. If you do good exercises, the muscle mass of heart also increase. To compensate the blood flow, we have a good collateralized flow in the arteries in the heart. So suppose if you are doing exercise, good exercise, you are running, you are doing weightlifting, you are jogging, your biceps are forming, you are making biceps and triceps, but your heart muscles are also getting stronger, and they are getting good collateral flow. If you have a good collateral flow and if you have a very good blood flow in your heart, even though if you get sometime if you are unlucky, you have any blockage in one artery, you will have a multiple collateral to flow, and your heart failure chances and getting a massive heart attack decreases. So the muscle mass also protect you from the heart attack. They develop more collateral, and positive hormones ultimately lead to the better survival.
Thank you. Dr. Sahil, we were discussing interaction between various organ systems. So we realized that the muscle, skeletal muscle and the heart talk to each other. When you exercise more, the heart becomes healthier. If the heart is healthier, it allows you to exercise more. And there are many hormones that the muscle secretes. Exercise promotes the secretion of a hormone known as klotho, Klotho, klotho,
Yes.
and one of the major sources is the kidney actually. The kidney secretes klotho. Klotho
Yes,
is named after a Greek goddess Klotho, Klothos, and this is known as the thread of life. So if Dr. Rahul is able to convince his patient to exercise more, if Dr. Yogendra is able to give the heart medicines so that exercise capacity increases, then the kidney is able to secrete more klotho and we are able to live longer, right? So it
Yes.
should be very simple, isn't it? So what are the advantages? What kind of medicines can we use for the kidney which help improve our lifespan and which help us live a happier life?
Sir, so I'll answer your question in two perspectives. Sir. So, for a healthy individual, if a person is totally healthy, then obviously the therapy for the kidneys is just going to make sure that you prevent to develop a disease. So, prevention will be better than cure in cases when a person is totally healthy. So, balanced diet, good hydration, good sleep, and avoidance of nephrotoxic agents. That's going to be a formula for someone who wants to maintain their kidneys healthy. So the second facet of it would be if a patient already has a diseased kidney, and then there are going to be some drugs which are going to be renoprotective, which, as you rightly said, that they'll help us to live longer and live in the right ways. So amongst the renoprotective drugs, ACE inhibitors and ARBs, they are going to form the backbone. On top of it, if at all a patient is diabetic, and probably even if the patient is non-diabetic these days, SGLT2 inhibitors can offer good renoprotection. And then new drugs like non-steroidal MRAs, these are recent in the pipelines, along with GLP-1 RAs. So all these medicines, even though they may not be directly acting on the kidneys, but they have been seen to offer renoprotection, and that is all what we look at, that how can we increase the quantum of life for our patients. I mean the renal life of our patients.
If we use the right drugs, glucose-lowering drugs, metabolically active drugs, we can actually tell our patients that yeah, we are giving you insurance. This insurance will work for your heart, for your pancreas, for both the left and right kidney, and you will be able to add life to years and years to life. I recently learned a new English word, Dr. Rahul. Actually, a Japanese word which has been borrowed by English, and the word is koku shobi, KOKUSHOBI. Now, the Japanese are facing a heat wave, so now they've got a few days where the temperature crosses 40 degrees centigrade. So they coined a new word for that. Kokushobi is a day when the temperature is more than 40 degrees, 40 degrees centigrade. So, Dr. Rahul, in the last 1 month, how many Kokushobi days have you experienced in
I believe the whole month was Kokushobi.
It would be 31 days out of 30. Yeah.
Yes, sir. Yesterday it was 46.
So let's take our last question, and we begin with Dr. Sahil again. We are speaking of global warming every day, global warming, and we see how it impacts each and every aspect of our life. But have you ever thought that global warming affects metabolic syndrome as well, metabolic health? So let's speak from a nephrology perspective. Heat and nephropathy, heat and acute kidney injury. What comes to your mind, and what take-home message would you give to our audience, that is physicians across India, and then to the public at large, each and all our fellow citizens?
Sir, so everyone knows, sir, and you have rightly asked the correct question, that in extreme heat, it is going to be too demanding for all the organs, and kidney, being a part of the ecosystem, obviously deserves to be taken care of in the better ways. So with the extreme heat, sir, obviously dehydration is something which will prop up in everyone's mind, and everyone's effort would be to increase as much as hydration as possible, and that what effectively should be done by one and all. The second is if someone is on drugs which put someone at risk for rhabdomyolysis, then this is the time when these people will have higher risk of rhabdomyolysis, citing because they keep themselves dehydrated. So the only and the most effective way to make sure that your kidneys don't take a hit is a very simple thing: to hydrate your body with as much as liquid as possible. So be it water, be it substitute fluids, but the quantum of fluids has to be taken in concerns with the kind of weather we have.
So thank you so much, and we all should be aware of the impact of heat on the renal system or renal health, and advise common sense measures. Our respected Prime Minister also said, drink enough water and make sure that you give water to someone else to drink. That would be the simplest. Dr. Yogender, in cardiology literature, we learn about Takotsubo cardiomyopathy, which we actually feel is an endocrine disease because it is preceded by an adrenal surge. And a question to everyone in the audience is, which famous character in the Ramayana died perhaps because of Takotsubo cardiomyopathy? He was given a news which he was not happy with. He felt upset. And then the description of his death, it's a very painful death actually, over a couple of days. Perhaps it was acute kidney injury which we couldn't resolve. Perhaps it was Takotsubo. Perhaps it was both of the above. but it might have been frustrated by heat as well, apart from the bad message that he got about his son's banishment. So look at the Ramayana and see how we can learn more about Takotsubo cardiomyopathy and also about heat and nephrology. But the question, Dr. Yogender, is heat and cardiology, heat and the cardiovascular syndrome, and heat-associated cardiomyopathy. Do these do these phenomena play out in your OPD on an everyday basis, especially in summer?
So, actually, honestly speaking, heat itself is somehow related to cardiovascular disease because dehydration is one of the risk factor for hypercoagulability. In cardiovascular problems, most of the problem arises because of the hypercoagulability, be it because you are losing the plasma or water from your bloodstream. So if there is this extreme heat and you are dehydrated, you have a high chance of development of multi-organ dysfunction, including the heart attacks. Because of the dehydration, there will be formation of acute clots in your coronaries. Sometimes because of the heat, people have ultimately acidosis, other problems, especially diabetic patients develop DK very early, and the DK, diabetic ketoacidosis, because of dehydration. They are diabetic and they are already dehydrated, and heat also leading to the dehydration. I have seen many patients with diabetes come in OPD. They said, I am taking medicine, but I got the heart attack. Why? I said, because you went into the heat, and now it is a double hit due to dehydration. One is diabetes causing, another is the heat causing. And so that's why your blood is very thick, and now you have a clot, substance of clot in coronaries. So heat as such causes a lot of heart attacks. So there is a recommendation that you should drink enough water, at least 2 to 2.5 liters throughout the day. Keep hydrated, drink any form of the liquid, and that's how you can prevent any heat-related heart complications.
Thank you for this message, and thank you for this proactive approach as well. That if you just add the concept of water hydration to routine OPD counseling, you can actually improve health. Dr. Rahul, global warming and endocrinology, what comes to your mind, top of the mind?
Sir, again, adrenal. And before that, the answer to your earlier question was Acharya ji.
Yeah.
Mahabharata.
Also in the mind, Dhritarashtra. Yeah, Dhritarashtra, when he was told that Ram has to be banished. So he had an attack. And when you read the history, when you read the description of how he passed away, actually it was either acute kidney injury, which the nephrologist didn't take care because Dr. Sahil wasn't there at that time. And then they didn't do the EGFR, and then they didn't do the serum creatinine also, and they didn't have IV fluids. Or it was a Takotsubo. So that's true.
Yes. And if we talk about the dehydration and the heat and endocrine system, so definitely are first and foremost the cortisol. It comes to my mind, and whenever there is a situation of dehydration, then we will have a counter-regulatory hormone surge, and this cortisol, growth hormone, epinephrine, they all are endocrine hormones. Their level goes up, and they increase the renin-angiotensin-aldosterone system. Thereby, they can worsen both of the systems of nephrology as well as cardiology, leading to worsening of the outcomes that a patient can have. So, cortisol is my take for this dehydration.
And now we see that metabolic syndrome is linked to so many things beyond what we read in the book, and all are interconnected. And then it's linked to our environment and ecosystem as well. So, for example, global warming, the heat that we are going through. And I think in Hindi and English, we will soon need a word for days where the temperature is more than 50 degrees centigrade. The way we are.
Definitely.
When we talk of physiology, all things end at the kidney because that is the excretory system. So perhaps let's take last comments from Dr. Sahil. Dr. Sahil, in your evolution as a nephrologist, and how has the concept of metabolic health changed in your mind, in your patients? So first of all, evolution from a morbidity point of view in your OPD, in the dialysis unit, and then evolution in your thought process, metabolism and nephrology.
So, the central thrust of treatment of any disease is going to be small. We talk about any branch, but so while I look at the evolution in nephrology per se in terms of morbidity and mortality, I believe that we as nephrologists have come ages with the kind of dialysis which we can offer to our patients. Gone are those days when the dialysis could keep you alive just for 2 years. In India now, people have lived on dialysis for over 2 decades, which speaks volume about the kind of paradigm shift in the kind of dialysis which we have had over the last 30-35 years. And second thing is obviously the mortality. If I talk about considering that the prevalence of CKD has been rising thick and fast. So in terms of that, the numbers will always be higher upcoming years because of the kind of diabetic population we have, kind of crosstalk between organs we have. So mortality, I would say, would be more contributed by chronic kidney disease in coming years. But mortality, morbidity as such has been increased with kind of advancement we have.
So point well taken from Dr. Sahil. We have come a long way. That was his final comment. And actually in 4D as well, we've come a long way. This is season 3.0 going on of detailed discussion and dialogue in Indian diabetes. And every week, every episode, there is something new to learn, something new to gain. If we can translate, if we can just convert this into even a tiny change in our practice, the way we think, what our attitudes are, the way we behave, so our attitudes and our behaviors, and then C would be for communication and choices, what choices we make in the clinic, that will make a huge difference to metabolic health in our country. Dr. Sahil, thank you so much. The name Bagai comes from the word Bag, which means tiger actually in Hindi or Sanskrit. So what tiger-like message would you have for our audience today? And our topic is metabolic syndrome, interplay with the kidney, heart, hormones, everything under the sun.
So I would say that kidneys are usually the most dangerous organ in the body. They take for a long number of years before they react. It's just that everyone who is at risk for metabolic disorders should act in time. And whatever I have seen in my experience is that in India somehow most of us are improving or talking about the number of drugs which we will be on rather than the target level. I would only like to get a bit of my country that it is just not about the number of medicines you are on, it is always about the target levels of any particular thing which we are talking about, be it thyroid, be it blood pressure, be it diabetes. So just don't look at 2 tablets a day, 5 tablets a day, 7 tablets a day. Look at the numbers whether they are target. I'm quite sure that if you maintain your numbers as closer to as what science says, the end organ damage is going to be minimal, and that goes and set for any organ.
So focus on the target, and in a very tiger-like fashion, you focus on the targets and you are able to treat your patient better. And multiple targets we should look at. And then Dr. Rahul, the word Rahul, what does that mean? That means a conqueror, somebody who conquers all miseries. I mean, I would love to consult a doctor whose name is Rahul, because then I'm sure that I'll be taken good care of. But Rahul also means efficient. So in one single sentence, but the sentence can be as many words as you want. I mean, that's a separate matter. But in one single sentence, a take-home message for all our colleagues.
So the take-home message would be that, which I tell to all my patients, that for this journey, for this weight loss journey that you are here for, at least climb the first stair. At least climb the first stair of lifestyle modification. So to have this lifestyle modification, the first and foremost is to have a balanced diet and a sustained and a consistent effort for whatever you are doing. If you are walking for 30 minutes, do it for 30 minutes daily at least. Just be consistent in your effort. That is my whole take-home message. That would be to have a consistent, balanced life.
So consistency. And then Dr. Yogender. Yogender means Lord of Yoga, and Singh means lion. So today we have the tiger. Dr. Bagai is with us, and then we have lions as well. So a lion-like, a lionesque message for our audience before we conclude.
So my take-home message is that, sir, their prevention is better than cure, and I always tell my patient that 95% disease is preventable in cardiology. If you adopt a good lifestyle, if you are doing best of your ability, you are doing exercise, you are your healthy eating habits, you don't have any bad habits, there is the least chances that if God is not kind to you, then only you have a heart problem. Otherwise, if you are adopting a good lifestyle, then you are in safe hand. You will be as perfect as anyone can else be. So my take home is that you just continue with your good lifestyle, rest, leave on the God. And I think that simple 7 steps, like, controlling your diet, lifestyle, low salt, not to smoke, not to do alcohol, jogging, less stress, and good sleep. So these are the 7 steps. If you adopt, then you will have a very better life, and you are being cardiac. You will have less chance of cardiac disease.
Thank you so much to Dr. Sahil for being with us, Dr. Rahul and Dr. Yogender. But most of all, thanks to all of you. All of us together, we make 4D dynamic, and we try to help our country become a healthier and happier nation. We've spoken of so many aspects. Let's just add one line before we leave, and that is metabolic hygiene. The same way you encourage your patients to practice hygiene in terms of their lifestyle, remind them not to forget their statins, not to forget their SGLT2 inhibitors, and their glucose-lowering drugs. The same way Dr. Parashar enjoined us to practice consistency in lifestyle. Take your statins and SGLT2 inhibitors and DPP4 inhibitors consistently. If we have metabolic hygiene, that means we have clean glucose, clean lipids, clean EGFR and UACR, automatically we will have a hygienic and a healthier life. With that, I'd like to thank everyone. Special thanks once again, Dr. Sahil, Rahul, Yogender, for being with us. Jai Hind, everybody. Jai Hind.
Thank you, sir. Jai Hind.
Thank you, sir.